Hello everybody. Today we are going to start cardiovascular system. First we are going to discuss few properties of the myocardium and then conducting system of the heart. So now let's start. Muscles of the heart are mainly of two types. Number one, myocardium. So I'm writing here myocardium, and second time is modified myocardium. Modified myocardium. So normal myocardium, we all know that this is the muscle which is present within the atrium and ventricle, and they are contractile in nature. So contractile tissue is the normal myocardium. But if you look at the muscles of conducting system of the heart, they are composed of modified myocardium. So modified myocardium is important for MCQ. This is part of the conducting system of the heart. So if I ask you that SA node, AV node, they are composed of which type of muscle, your answer will be they are modified myocardium, not that like that of the simple myocardium. So why it is known as modified? What kind of modification is happening? To understand that, first of all, we have to look at what are the features of normal myocardium. So number one, normal myocardium is a striated muscle. We all know this point. So it is a striated muscle. And striations is due to presence of alternate dark and light band, and that is due to actin and myosin. We have to remember that myosin, which is responsible for muscle contraction, which type of myosin there? That is myosin type 2. So myosin type 2 is responsible for muscle contraction in cardiac muscle also, skeletal muscle also, and smooth muscle also. Now in heart, we have to remember that myosin, which is composed of heavy chain and light chain, there are two special variety of heavy chain present in myosin 2 in case of heart, that is alpha myosin heavy chain and beta myosin heavy chain. So myosin is composed of heavy and light chain. The heavy chain which is present in case of heart, that is a special type. Alpha myosin heavy chain is dominantly present in the atrium muscles, and beta myosin heavy chain is dominantly present in the ventricular muscle. Right? So Genoa is saying that alpha myosin heavy chain and beta myosin heavy chain, both of them are present in atrium and ventricular muscle, but atrium having dominantly alpha myosin heavy chain and ventricle having dominantly the beta myosin heavy chain. So this is an extra point you should remember. Now second point I'm writing here. Second point is that presence of single nucleus per cell. Okay, so within myocardium cell there is only one nucleus. This is in contrast to skeletal muscle which contain multiple nucleus, and single nucleus is also present in smooth muscle. Single cell, single nucleus, right? So that is single nucleus. Now point number 3 is very important. There is presence of a specific structure in case of myocardium cell, and that is known as intercalated disc. Intercalated disc. Okay, so this is an exclusive feature of myocardium. What is intercalated disc? It has been asked in MCQ, so try to understand. Suppose this is one myocardium cell, right, and this is another myocardium cell. These two myocardium cells will remain connected with one another with the help of a protein molecule, that is desmosome. So I can understand that the desmosome is connecting the plasma membrane of two myocardium cell. This area where the desmosome is connecting two myocardium cell, under electron microscope, this area looks like a dark color area or dark color line. This dark color line is nothing but known as intercalated disc. So I can understand like this, that intercalated disc is nothing but it is the fusion of cell membrane, fusion of plasma membrane of myocardium cell with the help of desmosome. Desmosome, right? So desmosome is connecting to myocardium cell membrane, and that is nothing but intercalated disc. Because it is connecting to myocardium cell, I can also understand that intercalated disc is nothing but it is the mechanical attachment point between two cell. Mechanical attachment point between two myocardial cell. Very, very important. So intercalated disc is an exclusive feature of myocardium cell, right? Now, at the area where these intercalated discs are located, at the same region, there are presence of certain channels between one cell to other cells, right? And this channel we have discussed in general physiology. The channel is known as gap junction. So this is also a special feature of myocardium cell, कि gap junction may be present in smooth muscle. We have seen under smooth muscle discussion that gap junction may be present on smooth muscle, but it is not present in skeletal muscle. So I'm writing here the next point, that is the point number 4, presence of gap junction. Okay, so gap junction is present in case of myocardium cell. You know that gap junction is composed of connection protein, and gap junction contain a channel pore through which small molecule like sodium, calcium, they can move from one cell to other cell, right? So due to presence of this gap junction, what is the additional advantage of the myocardium cell, that we'll try to understand. So suppose I am stimulating one of the myocardium cell here. Whenever you stimulate, there will be generation of action potential, and action potential means there will be entry of calcium in phase number 2. We'll be discussing in the next class, right? So whenever calcium is entering in one cell, that cell is going to contract, no problem. But due to presence of this gap junction, the calcium will easily move from one cell to the other cell within fractions of second. That means I can understand that in case of myocardium, all the cells which are connected with one another, they will get this calcium within fractions of second whenever you stimulate at one point of myocardium, right? So you try to understand. Suppose you have this atrium muscle, right? Atrium, okay, and SA node is stimulating from a single point from here. So whenever SA node is stimulating this nearby cell, this cell will get the calcium, and that calcium will be easily delivered to the other muscle cells of this atrium, because of which what will happen, all this atrium muscle, both of these atrium muscle will contract simultaneously. Getting my point? So due to presence of this gap junction, I can understand that all these muscle cells which are connected with one another, they are going to cause contraction simultaneously, and this simultaneous contractile property of the myocardium cell is known as, all of you know, this is known as syncytium property of myocardium. Syncytium property of myocardium. So myocardium is a functional syncytium tissue. Functional syncytial tissue due to presence of this gap junction. So now you are seeing that gap junction is connecting two cells, because through this gap junction the calcium charge molecule, sodium, potassium, they can easily pass through. That means gap junction is an electrical connection between two myocardium cell. Electrical attachment or electrical connection between two myocardium cell. So previously we have seen that intercalated disc is an mechanical attachment point, and now we have seen that gap junction is an electrical attachment point. And where the gap junction are located, I told you that the gap junctions are located in the same area where this intercalated disc is there. So now I can understand that at the level of intercalated disc, the myocardium cells are mechanically attached with one another also, as well as they are electrically connected with one another due to presence of gap junction. That's why it is written in books that intercalated disc is the electromechanical attachment point. Electromechanical attachment point between two myocardium cells. Getting my point? So please note down that due to presence of intercalated disc, cells are mechanically connected, and due to presence of gap junction, the cells are electrically connected, and because they are electrically connected, myocardium is behaving like a functional syncytium. But you have to note down that atrium muscles forms a separate syncytium, and both the ventricle forms another separate syncytium, because there is a divider between this atrium and ventricular muscle. You must be thinking that why all the chambers are not contracting simultaneously. That is due to presence of a fibrous tissue ring which is separating the atrium muscles from the ventricular muscle, and that's why both the atrium is forming a separate syncytium, both the ventricle is forming another separate syncytium part, right? So this is about the syncytial property of myocardium. And the last point which I'm writing here is point number 6, that is there will be presence of branching in case of myocardium cell at a regular interval. So there will be presence of branching, right, at a regular interval. So after understanding all of this point, if you look at the diagram which is given in book, right? So this is the diagram I have taken from book. You can easily find out that single nucleus is present within a single cell. So this is the single nucleus. Okay, so this is the nucleus. Now two cells are connected with one another, and there is a dark color line, dark color region. So this dark color region is nothing but your intercalated disc, and at the same area where this intercalated disc is present, the gap junction will also be present here. And you can easily find out the regular branching pattern in case of myocardium cell. So they branch out with one another, which is completely different from skeletal muscle, because skeletal muscle is a single longitudinal fiber. So if I go back to this all point, okay, and now if I ask you, try to correlate all this point with skeletal muscle and see which one is different, which one is similar. So the first point, striated muscle, obviously the skeletal muscle is also a striated muscle, so this point is similar in both of them. Then single nucleus is present in myocardium cell. We know that multiple nucleus is present in skeletal muscle, so this is not similar. Intercalated disc, I told you already that this is an exclusive feature of myocardium, so this is also not present in skeletal muscle. Gap junction is also not present in skeletal muscle, and because gap junction are not present, they are not syncytium. Skeletal muscle is not syncytium, and branching is also not present in case of skeletal muscle. So within this 6 point, only the first point is similar between myocardium and skeletal muscle. All other are different from skeletal muscle, right? So this is important for your MCQ, although the points are simple, but try to remember all this point. Now we are coming here, the modified myocardium, right? So why it is known as modified? Okay, what kind of modification is happening in this conducting system of the heart tissues, right? So number 1 point, okay, there will be presence of very less number of actin and myosin. Actin and myosin's number or amount is very less in case of modified myocardium, obviously, because they are part of the conducting system. Okay, they are not going to generate contractile force, so that's why actin myosin's numbers or amount is less, and because of which striations are also fewer in case of modified myocardium, right? Striations are also lesser than normal myocardium. Second thing, very less number of cell organelles. Okay, very less number of cell organelles are present in case of modified myocardium, right? So cell organelles numbers are also very less. Like for example, mitochondria will be lesser, Golgi body, they are lesser in modified myocardium. And number 3, very important, that there will be presence of a small round cell. So I'm writing here, presence of small round cell within the conducting system of the heart or within the modified myocardium. This cell is known as P cell. All of you know that this P stands for pacemaker. This stands for pacemaker cell. So what I'm saying, all part of the conducting system, they are made up of which kind of myocardium? Modified myocardium, right? And this modified myocardium contain a small round cell, and that cell is known as P cell. P stands for pacemaker cell, meaning pacemaker cells is present within each and every part of conducting system of the heart, starting from SA node, AV node, bundle of His, and Purkinje fiber. So what do you mean by this pacemaker cell? We all know that pacemaker cell means they are capable of generating spontaneous impulses. So I'm writing here, they are capable of generating spontaneous impulses. Okay, spontaneous impulses without the help of, without the stimulation of sympathetic or parasympathetic system. Getting my point? So pacemaker cell meaning is that they can produce heartbeat spontaneously, automatically, even if you cut your sympathetic and parasympathetic system from the heart. This spontaneous heartbeat production or spontaneous impulse production capacity is known as automaticity of heart. This is known as automaticity property of the heart. Very, very important. So automaticity means this is automatically or spontaneously beat production capacity, and this is present in each and every part of the conducting system. So automaticity is a property of the SA node, AV node, bundle of His, as well as Purkinje fiber. Although if you look at the automaticity power, how do I understand? If you look at the rate of automaticity, then this rate is different in different part of the conducting system. Getting my point? So because of the presence of pacemaker cell, all part of the conducting system, they have this automaticity property. But now if you look at the rate, then SA node has a automaticity rate which is very, very higher, that is 60 to 80 beat per minute, which can maximally go up to 100 beat per minute, right? Then AV node and bundle of His, they are also capable of producing heartbeat spontaneously, but their rate is 40 to 60 beat per minute, right? And the Purkinje fiber, okay, they are also capable of beat production, but the rate is 15 to 40 beat per minute. So now if you look at that automaticity rate, then I can understand that AC node is the most powerful, right? And the beat production capacity at the level of AC node is 60 to 80, which is highest among all part of the conducting system. Because of which you know that SA node is the dominant tissue which has inhibition or suppression on other part of the conducting system, like for example AV node, like for example bundle of His, like for example Purkinje fiber. What I'm saying, just try to understand that SA node is like the head of the department. So when the head of the department is present, then what will happen? This AV node, this bundle of His, the Purkinje fiber, they are the other faculties. Okay, they will remain inhibited. So SA node is the powerful. He is saying that AV node, bundle of His, Purkinje fiber, all of you, you don't have to produce heartbeat. You just conduct my impulses. Because SA node is the powerful, he is giving some instruction, and SA node is generating beat. The other part, AV node, bundle of His, Purkinje fiber, although they are capable of producing beat, but in normal heart, they are not producing any heartbeat because they remain under the suppression of SA node. This kind of suppression is known as overdrive. This is known as overdrive suppression of SA node on other pacemaking cell like AV node, bundle of His, and Purkinje fiber. So this AV node, bundle of His, and Purkinje fiber, they normally remain suppressed because of the dominant SA node, but they are capable of generating spontaneous heartbeat. So they are also pacemaker, but this kind of pacemaker is known as latent pacemaker. So latent pacemaker means normally they are sleeping, but whenever requirement is there, they can reactivate their pacemaking capacity. So normally SA node is the dominant one and he is producing beat in our heart. That's why it is known as that SA node is the pacemaker of the heart. So if I ask you why the SA node is known as pacemaker of the heart, because he is the dominant, he can produce maximum heartbeat. So this SA node is pacemaker due to maximum heartbeat production at the level of SA node. All other pacemaker, they normally remain suppressed and they are known as the latent pacemaker. So I told you already that this rate which I have written here, these are the automaticity rate. Automaticity rate means even if you cut the sympathetic and parasympathetic system, this rate will continue, means SA node will going to produce a beat with a particular rate even if you disconnect sympathetic and parasympathetic system. With this concept, there is a famous MCQ that what is the resting heart rate in case of transplanted heart. Getting my point? So they are asking MCQ that a person who has a transplanted heart, what is the resting heart rate? So obvious thing is that if you look at here, that automaticity rate of SA node is 60 to 80, which can maximum go up to 100 beat per minute. So whenever you disconnect sympathetic and parasympathetic system during this transplantation, the resting heart rate will be near equal to maximum, and that is 95 beat per minute. So this information you have to remember that in case of transplanted person, the resting heart rate is equal to 95 per minute because we have disconnected the sympathetic and parasympathetic system. Now there is a more deeper question that if a person with a transplanted heart is doing exercise, okay, so now this transplanted heart patient is doing exercise. After recovery, he is doing exercise. What do you think? His heart rate will rise during exercise or not? Because you have disconnected your sympathetic and parasympathetic system. So, what do you know? That if a normal person is doing exercise, suppose I am doing exercise, what will happen? Immediately my heart rate will start rising. Even before the starting of exercise, the heart rate can rise up, and that is due to sympathetic stimulation and parasympathetic inhibition. But in this transplanted heart patient, okay, already the sympathetic and parasympathetic system of the heart is disconnected. So what your answer that during exercise the heart rate should rise or not? The general answer is it should not rise, but you have to think of that whenever this transplanted person is doing exercise, his sympathetic system in the body will be activated, and sympathetic system which is connected in the adrenal medulla, they will be activated and they are going to produce epinephrine and norepinephrine. Now this epinephrine and norepinephrine is going to act on the beta 1 receptor of the heart, and because of this there will be increase in heart rate. So you must be thinking beta 1 receptor, why it is not disconnected? Remember, you have only disconnected the sympathetic and parasympathetic system of the heart, but the receptors are present on the cell membrane. It is still there. So this receptor can be stimulated if there is presence of circulating epinephrine and norepinephrine. And where from this circulating epinephrine and norepinephrine is coming? This is coming from adrenal medulla. So whenever a person with a transplanted heart is doing exercise, first this epinephrine and norepinephrine has to rise, and then the heart rate will rise gradually. That's why it is said that resting heart rate during exercise will be raised in case of transplanted heart also, but this rise of heart rate will be gradual and slow rise of heart rate, not like that of the normal person where heart rate rises immediately and to a very high level. Getting my point? So this point you have to remember about transplanted heart, right? So now we were discussing that due to this overdrive suppression. So overdrive suppression is a property of the SA node. Because of this overdrive suppression, the latent pacemaker normally remains sleepy. They are sleeping in your heart, but whenever requirement is there, it can be activated. So suppose due to certain reason, the SA nodal conduction is not going to the other part of the heart. So what will happen? This AV node will be reactivated and it will start beating, right? That is the meaning of latent pacemaker. So you try to think of a condition of complete heart block. So complete heart block. You try to think of this clinical scenario. Suppose the complete heart block is preventing any impulses going to the level of the ventricle. So all of you know that if there is a complete heart block at the level of this AV node, what will happen? The ventricular muscle, they are not going to get any kind of impulses. But after certain point of time, this Purkinje fiber which are present within this ventricular muscle, they are going to be reactivated and they are going to produce beat. That's why we discuss this topic like this, that whenever there is a complete heart block, there will be, okay, so whenever there is complete heart block, there will be asystole of ventricle. Why there will be asystole of ventricle? Because the impulses are not coming to the ventricular muscle. So ventricle will stand still. There is no contraction from ventricle. But after certain point of time, the Purkinje fiber will be reactivated. Why it is taking some time? Because normally Purkinje fiber remain under the inhibitory control from SA node. So whenever there is a complete heart block, suddenly Purkinje fiber will think for certain point of time that he will wait, that the impulse is coming, but whenever the impulse is not coming, then the Purkinje fiber will take some measure to reactivate the heart rate once again. So after a period of asystole, what will happen? The Purkinje fiber will start beating. The Purkinje fiber beats. Okay, Purkinje fibers start beating, right? So this Purkinje fiber beat, which are produced in case of complete heart block, this is known as idioventricular. This is known as idioventricular rhythm. NEET PG has asked question that what is the rate of this idioventricular rhythm? I can easily understand that whenever Purkinje fiber is beating, it will produce a beat of 15 to 40 beat per minute. So the rate of idioventricular rhythm is 15 to 40 beat per minute. Okay, but I told you that this rate will only start after a time gap. So first there will be an asystole, and then there will be a time gap. The guidance is saying that this time gap is generally 5 to 20 seconds. So it varies from person to person, but after the asystole, the Purkinje fiber will start beating after 5 to 20 seconds. Now this 5 to 20 seconds is very crucial for certain organ like brain. Guyton is saying that if the brain is not getting blood for greater than 4 to 5 seconds, right? So during this period of asystole, if this time gap is greater than 4 to 5 seconds, then the brain is going to suffer from hypoxia, and that hypoxia will leads to dizziness. Okay, that hypoxia will leads to dizziness. There may be fainting also. And the person may fall on the ground also. All these symptoms, this dizziness, fainting, which is occurring due to this asystole of the ventricle, is under the heading of Stokes-Adams syndrome. So this is known as Stokes-Adams syndrome. Getting my point? So Stokes-Adams syndrome, this Stokes and Adams, they're the name of scientist. They told that due to asystole of the ventricle, okay, if the fainting, if the dizziness is occurring, then that is known as the Stokes-Adams syndrome. So what is the cause? Cause here is the complete heart block is the cause of the Stokes-Adams syndrome. Although Stokes-Adams syndrome can also occur in case of ventricular fibrillation, because you know the ventricular fibrillation means ventricle is not able to pump properly due to huge amount of heart rate, and that will also decrease the blood supply to the brain, that will leads to dizziness or fainting. So due to asystole of the ventricle and dizziness, fainting and the fall on the ground is occurring, that is part of the Stokes-Adams syndrome, right? So this is all about your normal properties of the heart muscles that we have discussed. Now we are going to next part, that is the conducting system of the heart. So conducting system of the heart is very easy. Okay, all of you know this thing. So it starts from the SA node. So suppose this is my SA node, okay, and then the next is the AV node. Suppose this is the AV node, right? So SA node and this is AV node. First MCQ, what is the location of this SA node and AV node? Okay, now in physiology book you will find out that SA node is located close to the superior vena cava opening, and AV node, it is located on right side of the interatrial septum on the posterior aspect. But if you look at the anatomy book, they will give you some different description. So I have combined these two anatomy and physiology book, and here you look at the diagram where is the exact location of SA node and AV node. So this diagram is taken from a research article. So you can find out here the superior vena cava opening, okay, superior vena cava, and this is the area where the superior vena cava is opening. And in this area, this region, this is the location of the SA node. So this is the location of the SA node, and this one, this is the location of the AV node. Getting my point? So if you look at here, the SA node is located close to this anatomical structure which is known as this crista terminalis, right? And if you look at the AV node, so this is the AV node, okay, AV node, where it is located? It is located inside a triangle. This triangle is formed by, obviously boundaries will be there. So this base of this triangle is formed by coronary sinus ostium. The posterior boundary of this triangle is formed by tendon of Todaro, and the anterior boundary is formed by tricuspid valve leaflets. So you can find out here, this is the tricuspid valve leaflet which is forming the anterior boundary, and then you find out this is the tendon of Todaro forming the posterior boundary, and this coronary sinus is forming the base. So this area, this is a triangular area. This triangle is known as triangle of Koch, and AV node is located within this triangle of Koch. So look at here what I have already discussed. Okay, it is written here. The SA node, according to physiology, the location is posterior wall of the right atrium near the superior vena cava opening. This is written in Gnome. But anatomically, this is located in the groove between crista terminalis and corresponding sulcus terminalis, right? The AV node, it is physiologically located at the base of the right atrial septum, but anatomically it is the triangle of Koch, which is bounded by coronary sinus, tendon of Todaro, and the tricuspid valve leaflet. If you look at the length of this structure, then SA node is 10 to 20 millimeter long, but AV node is smaller one, that is the 5 millimeter long, right? So this information sometimes can be asked in MCQ, so try to note down this point. Now we are going back to our original diagram. So this SA node and AV node. Now all of you know that SA node and AV node, they are connected via three internodal bundles. So these are the three internodal bundle which is connecting the SA node and AV node. They are known as internodal bundle. Internodal bundles. Right. Anterior internodal bundle, that is known as bundle of Bachmann. Right. Then middle internodal bundle, that is known as bundle of Winckebach, and the posterior internodal bundle, that is known as bundle of Thorel. Right. So what is the importance of this internodal bundle? You know that from the SA node, the impulses will reach to the AV node through the atrial muscles also. Okay. So from SA node to AV node, impulse generally conducted through atrial muscles. But when the impulse is conducted through this specialized bundle like Bachmann bundle or this Winckebach or Thorel bundle, the conduction velocity is much higher in case of this internodal bundle. This important information you have to remember, that the conduction velocity is higher in comparison to atrial muscle in this internodal bundle, right? Then we all know that this AV node, okay, now it will give rise to bundle of His, and then the bundle of His will be divided into two parts, that is the left bundle and the right bundle. So in between, this is my bundle of His. Now regarding bundle of His, you have to remember one important information, that it is the only electrical connection, only electrical connection between atrium and ventricle, between atrium and ventricle, right? So bundle of His is the only electrical connection between atrium and ventricle. Why I am saying this? Earlier I told you that atrium forms a separate syncytium, ventricle forms a separate syncytium, and in between this there is a fibrous tissue ring. So bundle of His pierces through that fibrous tissue ring, and it makes a electrical connection between atrium and ventricular tissue. That is the meaning, that only electrical connection. Now after this, we all know that this left bundle branch will be divided into left posterior fascicle and left anterior fascicle. So this is left anterior fascicle, and this is left posterior fascicles, right? So fascicles means, it is bundles of fiber. It is bundles of fiber. So these fascicles generally they run through the endocardial region of the heart. So when these fascicles are running at the level of the endocardium region of the heart, what will happen? The individual fiber from these fascicles will be separated out. Means this fascicle contain multiple fiber, bundles of fiber. So when they are running in the endocardium region, more and more fiber will be separated out from here. So more and more fiber is separating out from here. This fiber which are separating out from these fascicles one after another, they are known as the Purkinje fiber. Getting my point? They are known as the Purkinje fiber. Now if you look at the right bundle, then there is no separate branching of anterior posterior. It will continue as a single fascicle, and again this single fascicle they will give rise to multiple fiber, and these are known as the Purkinje fiber. Getting my point? So now all of you know this conducting system of the heart. Okay, you must have read about this conducting system. Main important thing that you have to remember, that what is the time required for conduction of impulses through every part. What I am saying, suppose I am asking that we have understood that SA node is producing an impulses, and this impulses is traveling to the AV node. So this is my AV node. Now tell me, what is the time which is required from SA node to AV nodal conduction? What is the time required for SA node to AV nodal conduction? Your answer will be 30 milliseconds. Then the impulses has to travel through this AV node. The impulses has to travel through the AV node. AV node length is only 5 millimeter, but this small length, okay, the conduction through this small length is very, very slow, because of which there will be a long time interval, okay, at the level of AV node, and that is 100 millisecond. This 100 millisecond is known as the AV nodal delay. This is known as AV nodal delay. So whenever the impulse is traveling through the AV node from the upper part of the AV node to the lower part of the AV node, what is the conduction time? 100 millisecond. This is known as AV nodal delay. So you must have to remember that there is a range, and this range is 60 to 125 millisecond. That means if the conduction is faster, when the conduction will be faster through AV node, suppose the heart rate is higher. If the heart rate is higher, then the conduction velocity through the AV node will be a little more, and then this interval, the AV nodal delay, will be lesser. That is the 60 millisecond. And when the conduction through the AV node is very slower, like for example heart rate is very, very slow, then the AV nodal delay can rise up to 125 milliseconds. So that's why there is a range, but on an average you have to remember 100 millisecond is the AV nodal delay. Then after the AV node, the next part is the bundle of His, and that will be divided into left bundle and right bundle, we have seen earlier. The time which is required to cross this bundle of His, means from the upper part of the bundle of His to this lower part of the bundle of His, that is the His bundle delay. So this is known as the His bundle, okay, delay. Normally the His bundle delay is 40 millisecond on an average. Again, you have to remember that the range is 35 to 55 millisecond, right? So this is known as His bundle delay. Now this His bundle is located in the uppermost portion of the interventricular septum, right? So I can imagine my diagram like this, that this is my interventricular septum. This is my interventricular septum, right? So after the impulse is crossing through this bundle of His, now it is going to causes depolarization of this septal muscle. Am I clear? So the SA node has produced one impulses that is traveling down to the AV node, then it is passing through the AV node, and then it is passing through the bundle of His. Now whenever it is passing through the bundle of His, next structure is that muscles of the septum, that is the septal muscle. Now the impulses is going to causes activation or depolarization of the interventricular septum. Which part of the interventricular septum? The middle part of the interventricular septum will be depolarized first. So if I ask you, at which time point the ventricular depolarization start for the first time? When the SA node is producing one impulses at 0 time point. Look at my question. Suppose whenever the SA node is producing one impulses, that is a 0 time point. At which time point this ventricular depolarization will start? So this is the ventricular depolarization starting point. Okay, at which time point? Your answer is very simple, 30 millisecond. Then you require 100 millisecond for AV node, then you require 40 millisecond for bundle of His. So 30 plus 100 plus 40, so approximately 170 millisecond time is required for ventricular depolarization to start whenever the SA node is producing one impulses at 0 time point. Getting my point, right? Okay, now what is going to happen? Now these impulses is going to depolarize the septal muscle from left side to right side, like this. Okay, so now the depolarization is spreading through the septum. Okay, and we all know that in this septum the fascicles are there. So the fascicles are there like this. So the fascicles are there. So now the depolarization is traveling through this septum from left side to right side. Look at the direction of the arrow. So impulses is traveling from left to right side, and it is reaching at the apex of the heart. Apex of the heart. The total time, okay, the total time for the impulses to reach up to the level of apex is 200 millisecond. Means up to the level of this mid part of the septum, the impulse is reaching at 170 millisecond, and then it is reaching up to the level of apex in total 200 millisecond. That means 30 millisecond time is required to cross this septum from mid portion up to the apex of the heart, right? Now from this apex, we all know that impulse is going to depolarize both the ventricular muscle through this Purkinje fiber. So this Purkinje fiber are located, okay, and the impulses or the depolarization is going to depolarize both the ventricles simultaneously, and the depolarization will move from apex towards the basal part of the heart like this. It will move from the apex toward the basal part of the heart like this. The total time which is required for the depolarization to complete the heart activation. Okay, so the total time which is required for the impulses to reach from this apex towards the base is 220 millisecond. 220 millisecond. Getting my point? So from the apex, the impulse is traveling towards the basal region of the heart, and it is taking only 20 millisecond extra to complete the depolarization. So first MCQ that you must have to remember, that the total time which is required for complete depolarization of the heart, is 220 milliseconds. First you remember this MCQ first. Then you note down that when the impulse is traveling from this apex region towards the basal region or towards the base of the heart, the depolarization is occurring through Purkinje fiber, and we have already seen that Purkinje fiber is originating from this fascicle. So these are the fascicles. Fascicle means they are the bundles of fiber. And where the fascicles are located, I told you fascicles are located just below the endocardium, subendocardial region. So obviously, this Purkinje fiber, they will extend from this endocardium towards the epicardium region. And that's why we say that when the impulse or depolarization is traveling through the ventricular muscle, the depolarization occurs from endocardium towards the epicardium, endocardiums towards the epicardium, and the impulse will move from apex towards the base of the heart, apex towards the base of the heart. Getting my point? So now we can summarize this topic that SA node is producing on impulses. It is reaching to AV node in 30 millisecond. Then it is taking 100 millisecond to cross the AV node. Then it is taking 40 millisecond to cross the bundle of His. Now it is starting the depolarization in the septal region. And which part of the septal region? Mid part. So the total time to start here is 170. Then it is reaching up to the apex of the heart, and total time which is required is 200. Then from apex, both the ventricle is depolarized simultaneously. It is reaching to the base of the heart. Total time which is required is 220 milliseconds. So complete depolarization of the heart is occurring within 220 milliseconds. Right. So if I look at this time, then I can understand one thing very easily, that from this apex to the base, when the depolarization is moving, this is very fast because only 20 milliseconds is taken from apex to base. But if I look at this AV node, although it is 5 millimeter, but it is taking longest time to cross this 5 millimeter structure also. So if I ask you a genuine question, that what is the conduction velocity? What is the conduction velocity of impulses in different part of the heart, then your answer of fastest conduction, what will be your answer? Fastest conduction occurs in which part? So obviously we'll say that when it is going from apex to base, and from apex to base we have seen that the impulse is traveling through the Purkinje fiber. So the fastest conducting fiber in the heart is Purkinje fiber, and the slowest conduction, okay, slowest conduction is occurring at the level of AV node. These two MCQ are very important. If you look at the conduction velocity, you will also understand this phenomena very easily. So SA node has a conduction velocity of 0.05 meter per second. AV node has a conduction velocity of 0.02 to 0.05 meter per second. Purkinje fiber has a conduction velocity, this is very high, highest among all part of the conducting system, that is 4 meter per second. And the other part of the conducting system, like for example, suppose I am saying atrium muscles or the ventricular muscles, okay, or the bundle of His, all of them having a conduction velocity of 1 meter per second. Getting my point? So you may remember this conduction velocity. I have seen one MCQ where this Purkinje fiber conduction velocity has been asked. So you may recall this. Otherwise, you must have to remember that Purkinje fiber is the highest conducting fiber and AV node is the slowest conducting fiber within the heart. Right. Now Purkinje fiber conduction velocity is 4 meter per second. Could you compare this conduction velocity with the neuronal conduction velocity like motor neuron? Could you recall our previous discussion? Motor neuron has a conduction velocity of 70 to 120 meter per second. 70 to 120 meter per second. So in comparison to the neuron, this conduction velocity is very low. But within the heart, this is the fastest conduction velocity. Right. Now, the question is, why the Purkinje fiber conduction velocity is so high? Okay. So why the Purkinje fiber conduction velocity is very high? Right, this is my question. Why the conduction velocity is very high in the Purkinje fiber? So conduction velocity high means the electrical impulse is traveling through the Purkinje fiber with high velocity. Electrical impulse traveling through high velocity means resistance is very less. And you know, resistance is less means there must be some electrical channel which is decreasing the resistance between two cells, okay, and that channel is nothing but gap junction. So please note down that highest number of gap junction is present, okay, at the level of Purkinje fiber, okay, and obviously it will be lowest in case of AV node. Second thing, not only the gap junction, the fiber diameter is also an important factor for conduction velocity of impulses. Thicker the fiber, more will be the conduction velocity. So remember, the thickest fiber is there at the level of Purkinje fiber. Thickest fiber is present at the level of Purkinje fiber. Fiber means which fiber we are talking about? We are talking about modified myocardium fiber, because I told you the conducting system is composed of modified myocardium, right? So thickest fiber is present at the level of Purkinje fiber. Not only that, third point is also important. The action potential or the electrical impulses that is generated at the level of Purkinje fiber is of fast type, but it is very slow type in case of AV node and other nodal tissues. Slow type action potential is seen in case of AV node, right? So that's why this action potential, fast type and slow type, what is the meaning of this, you will understand in the next topic. But for the timing, you remember that because of the highest number of gap junction, because of the thickest diameter fiber, and because of the first action potential, the Purkinje fiber conduction velocity is highest among all part of the conducting system of the heart, right? So this is all about conduction velocity. Now if I go back to this diagram once again, so conducting system of the heart you have understood, okay, and you have also seen that the first part of the ventricle that is getting depolarized is the mid portion of the septum. Then the impulses is moving towards the apex, and then the last part of the heart is the base of the heart, which is depolarized. So there are very important MCQ from this region, that ventricular depolarization start from which part, and last part of the ventricle to be depolarized is which part. So I have discussed already and I have written here also. Look at this, right? So this is very important. For the atrial depolarization, there is no problem, because atrial depolarization start at the level of SA node, and atrial repolarization also start near the SA node. Both are the same area. But ventricular depolarization, the first part of the ventricle to be depolarized, I told you that it is the left side of the interventricular septum and it is the middle part. So two things you have to remember. If this is my septum, okay, this is the uppermost part, this is the mid part, and this is the lower part. The middle part of the septum will be depolarized, and if I ask you left side of the septum or right side, your answer will be left side of the septum, and it is the middle part that is depolarized first, and then the impulse will travel from left side to right side. So that is written here, that it is the left endocardial surface of the interventricular septum at the middle portion. This is the first part of the ventricle to be depolarized, right? And the last part of the ventricle to be depolarized is the uppermost part of the interventricular septum. Look at here, very important. So I told you that impulses travel from this apex towards the base. So obviously base will be the last part to be depolarized, but not only the base, this impulses has to depolarize this septum which was not depolarized earlier, right? So that's why this base of the heart as well as this uppermost, this word uppermost is very important, uppermost part of the septum are the last part to be depolarized. So that is written here, the uppermost part of the interventricular septum as well as the basal portion of the heart is the last part to be depolarized. Which sided base of the heart? If I ask you that it is the left sided base or the right sided base, it is the left posterobasal epicardial surface of the left ventricle is the last to be depolarized. So suppose you are getting option that uppermost part of the septum is also there in the option and base of the heart is also there, your answer should be base of the heart, because that is the last part. And if I ask you which base you are talking about, right sided ventricular base or left sided ventricular base, so left posterobasal is the exact word that you have to remember. Okay, so this is about depolarization. Now, during ventricular repolarization, where the repolarization will start? Okay, there are This is a little bit confusing because some of the student believe that repolarization also should start here, or some of the student think that repolarization should start from in opposite direction, that is the base of the heart. But Guyton is saying none of them are correct. The repolarization starts from the apex of the heart, and we all know that repolarization occurs in the reverse direction. Reverse direction means it will go from epicardium towards the endocardium. It will go from epicardium towards the endocardium, but it will first start in the apical region of the heart and then it will move towards the base of the heart. So if I draw a ventricle diagram like this, so first this apical portion will be repolarized and then the repolarization wave will move from this apex towards the base of the heart. This is clearly written in Guyton. If you don't believe me, okay, I'll show you the reference here. So first you look at these two references where depolarization part has been discussed. So the posterobasal area of the left ventricle are the last to be activated. Getting my point? So the last part is the posterobasal portion of the left ventricle, and this is given in electrocardiogram book, that is by Goldberger, right? And septal activation begins. So starting of septal activation occurs in the middle third of the left side of the interventricular septum. Very, very important. And Genong is also saying the same thing. In human, depolarization of the ventricular muscle start at the left side of the interventricular septum and move first to the right across the mid portion of the septum. So please don't make confusion here. Try to understand this. And now you look at the repolarization. I told you that repolarization direction is a little different. Okay. So what Guyton is saying? Guyton is saying the same thing that I told earlier, that because the septum and endocardial area of the ventricular muscle depolarizes first, it seems logical that this area should repolarize first as well. However, this is not the scenario, right? Therefore, the greatest portion of the ventricular must to repolarize first is the entire outer surface. Outer surface means epicardial surface of the ventricle, especially near the apex of the heart, especially near the apex of the heart. So this is very, very crucial, you have to remember. So you look at this diagram below. So this first diagram, this indicate that the ventricle is completely depolarized. So look at this color, the ventricle is completely depolarized, pink color. Now you look at this whitish area, this is the starting of repolarization. So you can easily find out that repolarization is starting here in the apical portion, and that is the epicardial, and then this whitish area is spreading towards the basal region of the heart. So this whitish area is spreading, and now this is completely repolarized heart, right? So this first diagram is a completely depolarized heart, and now this whitish portion means that is repolarization is starting, and then this is complete repolarization. So this diagram is also taken from Guyton. So this will make it clear that repolarization start from apical region, but depolarization start from middle portion of the septum on your left side, right? So this is all about the basic structural function, anatomy and conducting system of the heart. Okay, but before ending this session, I will show you one peculiar type of MCQ. So we have seen that depolarization occurs from endocardium towards epicardium, and repolarization occurs from epicardium towards endocardium. And what is the sequence of the normal depolarization? First, the mid part of the septum will be depolarized, right? Then it will move towards the apex, then it will move towards the base, okay, and uppermost part of the septum. This is the normal sequence. And when it is depolarizing this apical portion and base, okay, the depolarization is going from endocardium towards epicardium, right? And during repolarization, epicardium to endocardium is the direction. But look at the question from PGI Chandigarh paper. Repolarization of isolated muscle, and now this changes everything. Isolated muscle means which you have separated from the body. In these cases, depolarization as well as repolarization both occurs in the same direction, that is from endocardium to epicardium. Now, if you ask me what is the reason, sir, reason is not known. If you don't believe me, look at the same book that I have given reference earlier. For individual myocardial cell, okay, depolarization and repolarization proceed in the same direction. Individual myocardial cell means which you have separated from body, and D and re, which is in the same direction. However, for the entire myocardium, depolarizations proceed from innermost, that is endocardium, to the epicardium. The exact mechanism for this well-established asymmetry are not fully understood yet. So this is all about the first topic. Thank you.